activities, more also because you're just so down, like you can't get up to do anything. And so that lack of energy, fatigue, and not wanting to get up to do anything also is a part of the behavior. And then we have the emotional aspect of it. So that is that persistent, again, that word again, persistent sadness, or that empty feeling, and it lasts for 2 weeks. You cry for no reason. You know, I believe I struggled with depression at some point in my life. I remember in New York, I was looking for a parking space. Someone took my parking spot, and I burst out crying. And I knew something was wrong. I added a bunch of stuff that was going on. So if you cry for like the least little thing for no reason, and in combination with other things, then you know something is wrong. When you have that hopeless feeling, you feel like there's no hope, you feel helpless, there's that constant guilt or worthlessness. You feel like you've let everybody in your life down. That irritable feeling, you're irritable all the time, agitated all the time. And then the big one is the thought of suicide. If you have this constant thought of wanting to hurt yourself, wanting to hurt, not wanting to be here. So especially if you have the thoughts of suicide, the appetite, the sleep, the lack of interest, and the concentration, if that together, you have it persistently for 2 weeks, that's a concern. You need to see your doctor right away, talk to somebody, and get the resources that you will need. So why don't we quickly talk about causes of depression? There isn't any one specific causes. It can be genetics. It can be health concerns. So, I always tell people, when someone is diagnosed with HIV or cancer, half of the time, if they're under a good doctor's care and doing all the right things, I feel half of the time what kills them quicker is the mental health aspect of it. They're so depressed, and that's fear. So the genetics plays a role. So if it's in your family, someone in your family has it, a situation in your life circumstances can lead to that, or health condition can also lead to that. So there isn't one key thing where, and as Sister Dilla said, we can't draw blood to figure out, say, oh, this is exactly that's what's happening, and that's why you're feeling this way. Next slide, please. Okay, so we're going to spend some time on suicide and self-harm. So self-harm is when someone hurts themselves purposefully, intentionally. And it is very common among us women than men. It is also very common among our teens. So when someone they don't really mean to kill themselves, but it's just they're in pain, and it's the idea of relieving themselves. But however, they also have a higher risk of attempting suicide. And by dying by suicide if they do not get help. So yes, the intention normally isn't really that I want to kill myself. It's just I'm in pain and I want to get rid of the pain. But when they don't get the help, then they can end up committing suicide or dying by it. What tends to bring about self-harm? It tends to, as I said, begin in teens and early adult years. And it's sometimes the person will start and then they will stop. And sometimes it will be more consistent, and it just gives them a sense of relief. Someone is in a lot of pain, and they realize, sometimes it may even be an accident, they may cut themselves, and realize that if I'm focusing on that pain, I don't have to then think about all the stuff that I'm dealing with. I don't have to then focus on all the sadness that's going on. So, why don't I continue? Then they keep cutting. Some of the teen, they feel lonely, they're angry, they're helpless. When someone is really frustrated, they'll bang their head to the wall, and the idea is that, okay, well, I am focusing more of that relief that I'm getting, as opposed to that frustration, that anger that I'm also getting. There are some of examples of self-harm is that the cutting your skin with a sharp object, piercing your skin with sharp object, hitting or punching yourself, burning yourself, breaking some bones or bruising yourself. So those are things that and we're going to talk about resources, how to get help for all that. So if you have a teen who in the summertime, especially a girl who refuses to wear short sleeve, that's a red flag. For me, that's a red flag. If you constantly covering themselves, if covering and hiding when you're coming in the bathroom, hiding when you're coming, constantly making sure that covered up, that's a red sign. And I would really encourage that you pay attention and figure out if you see that there's a lot more scars than usual, dig deeper and figure out what's going on. That may be something that is happening. All right. We're going to talk about the suicide. So it is very complex, right? And it's by different factors. Mental health in general as a whole causes the suicide. Substance use, also the painful loss. You can lose somebody really, and it cuts you to the core. And so then you feel like, well, I might as well end it myself. Exposure to violence. When someone is under so much violence and so much trouble and they feel like there is no way out, I can't get out of this guy. He's hurting me. He's about to kill me. So why don't I do something to just get rid of the pain? Or social isolation. Sister Dillis spoke about the pandemic when we were all locked down. Some people struggled. It was really hard for people because people are social butterflies. They like to be around people. So when they did not have that support, that can also lead to that. What are some warning signs that someone is at a greater risk of suicide? When they're talking about or making plans of suicide. So when someone loosely say, well, I wish I wasn't here anymore, I want to do something to myself, then you have to probe more and figure out, do you have any plan? Do you have any intent? I always tell my patients when I'm talking to them and we do a safety plan, I said, well, tell me this. If you tell me when I hang up the phone, I am going to do X, Y, and Z, I know exactly what I'm going to do, then I am very concerned about you. So do you have a plan? You have an intent, how you want to go through with it? So that's concerning. When someone is consistently anxious and agitated and behaving recklessly, again, that alone isn't always an indicator, but that's something to look out for. When all of a sudden your teen or a sibling or family member is just, their behavior is out of nowhere. Talking about being a burden to others, when they feel like, I feel like I'm a burden, I'm hurt, I'm causing too much trouble in this family. Talking about feeling trapped or unable to bear any pain. Increased use of alcohol and drug use. That's a risk factor. Someone feeling hopeless, and having no reason to live. And again, that symptoms of depression, of the sleeping too much or too little, they isolate themselves, they're constantly withdrawing. So if you have a teen, yes, our teen now, they love being on the phone and being on the computer. And so I went to one of my mom's house in Maryland, and I said, where is everybody? She's like, everybody's in your rooms. And so she's downstairs by herself with her husband. We can figure out if the isolation is coming from with a lot of different things together, then it's a concern. Showing a lot of rage or talking about seeking for revenge or displaying extreme mood swings. If their mood is out of the world, is constantly swinging from left to right, then you have to look into it and seek for help. So those are the things to look out for when someone is having these signs and symptoms, where to look, where to go for help. And at the end, we have some resources, but just briefly, they've made it so simple. You can text or call a number 988, and that is a National Suicide Prevention Hotline number. I always tell people, if you're feeling really scared, like those thoughts are scaring you, walk into the nearest police station, go there and say, I don't feel safe. Or fire station, tell them you don't feel safe. Or go to the nearest emergency room or an urgent care. If you these places, someone will always provide the resources for you. Now, mental health, we have a long way to go in terms of making sure we make you comfortable, but you can always go to these places to get the resources that you need. Next slide. All right, so Barry, that's your turn.
All right, so I want to just make a comment on the depression and the anxiety piece, depression presentation before I transition to the anxiety part. I cannot stress enough how important it is for us leaders who have been chosen to help our kids, especially the junior youth. Their souls are kind of handed to us some way, because we have a rapport with them. If we don't, then eventually, if we engage them the appropriate way, we can win their trust. And for that reason, they will be coming to us mostly to share their struggles and their concerns with us. So today, I'm very excited because this is very important for us JY leaders to be intermediate between our junior youth and the parents, because not enough or inadequate education or not exposure to the education piece could leave our some of our parents in a position where they wouldn't understand what our junior youth are going through. So that depression piece can really compromise one's ability to see any hope for tomorrow, and that can lead to that state where I have no reason to live, because it's never going to get better. It's going to continue like this. What's the point of living? These kind of words are very important for us to pick on and explore further, so that hopefully we can engage our young generation to help them out. Now, the anxiety. So experiencing occasional anxiety is normal. When I'm asked to present, when I'm asked to preach, when I'm asked to stand in front of the church, when we ask our junior youth members, some of them to stand and give out some presentation, I'm sure if Papa Sasu continues to lecture, he will bear with me, or those of us who have been through colleges here. When one has to present in a classroom, you feel this intense, restless way that your mind is telling you something that, would I mess it up, or would I say something that is not acceptable? Would I make a mess out of myself? And would I really do something bad that I cannot really recover? These thoughts start creeping into your mind, because our brains are wired in a way that we use a terminology called the fight or flight ideation, where it makes you become aware, very much alert, so that you can prep yourself. Let me give an example. When you're walking across the street, New York, those of us from New York City are very much aware. When we walk with cars, the car will be coming and one will just be standing by. And whenever you feel the fear to run away from the middle of the road, your flight ideation, or your brain is wired in a way that your mind is telling you you should perceive that as danger coming. And so run or get out of that way. And our kids, our junior youth, our boys and girls, research is indicating that at that age, from 12 coming up or before 20, their frontal lobe is still developing. And for that reason, the emotions that is indicated in the frontal lobe is still in the development, is still developing at that stage. So anxiety becomes one of the challenges that human in general and our junior youth face. So when you feel that way for a short period of time, it is normal, because God has wired our brain circuits in a way that will keep us away from danger, to keep us from relaxing too much, to make us be able to prepare ourselves. It helps so much. But when it's prolonged for a period of time, when I'm after presenting, I'm still feeling the fear, the tense, restless feeling, and that continues for a period of time, then it becomes a problem. So the feelings of anxiety and panic interferes whenever it interferes with our activities of daily living. And it makes it difficult for us to be able to control that fear that is becoming an anxiety disorder. And we have to pay attention to that. So we will take a look at some of the symptoms of anxiety: nervous feelings and restlessness. You feel tense. So if you have a young kid coming to you and saying that I have no exams coming up, I have no major issue or event coming up, but I'm feeling really, really intense. I cannot sit still. I'm really nervous. I'm restless. And I'm perceiving that there's this danger coming, and I'm panicking, feeling like there's the doom coming upon me. And you can sometimes see the exhibit, the physical body exhibiting that this kid is really breathing. The heart rate is really fast, heart palpitation and hyperventilation, and sweating and sweaty palms and trembling. And this, when you start feeling these weaknesses in your joints because of your feeling this tense anxiety, then there's trouble. It gets to the point where it cripples or interferes with ability to concentrate. You can't stay focused, can't stay, so it's very, very, very common among our students who cannot really make it through their semester. Why? Because they have trouble focusing on a task or an assignment that has been given to them. So they will keep procrastinating, they keep putting it off until the due date comes in, and that also leads to another level of feeling of questioning their self-esteem and all that. So the anxiety is kind of related to the depression to a certain degree. It also can affect one's GI problems, difficulty breathing, and the urge to avoid issues. So this is very real, and it's an ongoing. People are good at masking these things, but it is really, really a challenge to those who are struggling with anxiety. Now, I want to spend a few times and have us go through, there are a long list of types of anxiety, but for the sake of time and not to overwhelm you all with so many of these, we want to focus on few of these types. We have generalized anxiety, which is what the symptoms is what I described. And that, if you go to your doctor's office in New York and some part of here in Maryland, we've been practicing that, where during triage, our nurses will conduct what we call a GAD-7 screening, generalized anxiety screening. They will ask you, in the past 2 weeks, have you been feeling all the symptoms that I just listed? And if you answer to that, they will trigger a conversation by your clinician where proper and further assessments will be conducted and referrals can be made. So I want to encourage us that.
And Bra Eric, I'm just gonna quickly, and also for primary care providers too, they are doing that nowadays. When you go to your regular medical doctors, because they've also recognized the importance of catching this on time. So all annual physicals and all of that, even follow-up visits, most doctors' offices or all of the doctors' offices are supposed to be asking those questions as well and make the necessary referral. Thank you.
Very well. Thank you so much, Mr. Dillis. My doctor not long ago gave me that screening, and I said, this is what I do on a daily basis at work. So let's encourage our youngsters that when they are given this, they should take it seriously, and let's make them comfortable to be able to give us, discuss some of those issues that they might be going through. One of the types of the anxiety is agoraphobia, the type of anxiety which brings about fear and avoiding places and situations that may cause us to panic and feeling like we are trapped or helpless. I feel like I'm going to be embarrassed, so I'm not going to talk. The other is a social anxiety. And JY leaders, JY teachers, let's really, really take note of that, because whenever we are trying to encourage our junior youth members to participate in group activities, and you see that some of them are holding back and having a rough time, coming out, it could be that they are facing this challenge. And for that, if you can, out of the group at an individual basics, you can engage them with a conversation, trying to explore that. We're not trying to train you to be mental health clinicians, but we want to impact the basic knowledge in order to engage a conversation where you can escalate that to professionals who can help assess this further so we can help them. Another type of anxiety is anxiety due to medical condition. There are some medical health issues like hypothyroidisms. All these things can cause anxiety. Panic disorders, selective mutism. It is a consistent failure of children feeling the fear to speak in public and in school settings and in places like when we meet in the JOI groups. Separation anxiety is something that some of our children here, our young junior youth, face a lot because some of them have separated from their families. So we should take notes of some of these things. When you identify some of these behaviors, you want to be able to see how you can engage them. Now, specific phobias, when kids have specific fear of certain specific issues or things, substance-induced anxiety, that is when one engages in drugs, which we'll come to that. We'll talk more about drugs a little later. When that medication may cause anxiety, there could be a prescription drug that may manifest in a form of anxiety. So when that happens, then let's try to talk to them. Now let's talk about a few causes of the anxiety. Medical issues, heart diseases, diabetes, COPD, drug misuse, which I said we will come to that, and chronic pain. Some of these things can cause one to be so much worried. And when one's family is sick and you or that individual is really worried about whether this person is going to survive or not for a prolonged period of time, that can potentially lead to an anxiety. Now, quickly, there are some risk factors that I want to call our attention to. There is studies that has indicated that anxiety can be associated with predisposition to genetics. When your family members might have been struggling with anxiety or other mental health issues, one can be born and be potential to developing that. Stress due to illness, stress due to so many other reasons, environmental stresses that can cause so much prolonged period of time that can cause anxiety. Like, let's look at the pandemic, how people feared even shaking people's hand or talking to people. Any symptoms of COVID, any symptoms of cold, one might feel like, oh, this is COVID, or this may be COVID, and am I going to die? And a prolonged period of time can cause your brain to believe that even if there is absence of problem, you're still going to believe that there is going to be a problem. So I'm really, really anxious about it. So let us be aware of this. We'll talk about the treatment later. Sister Dillis and myself will talk more about the treatment. So we'll move to the next slide, and for the sake of time, bipolar disorder.
It'd be better to unmute myself and start talking. So we're talking about bipolar disorder, and just like it is under what we call a mood disorder in a way. And just like bipolar means bi is usually, kind of like two opposite. So the two types of bipolar disorders that we usually deal with here is the manic episodes and depressive episodes. So bipolar meaning that sometimes, people get really excited, they feel on top of the world. They feel like, nothing can touch them. They feel like, they are all that in a bag of chips. They feel like they can, go out and do everything. So they have this, grandiose idea of themselves, what they can do. Sometimes, some people will even, go shopping and, just be elated, about life and do different things that normally is not, in their nature to do. At the same time, that same person, either within the same day, within a few days, within, a few hours can go from being this, hyperactivity kind of person, on top of the world and everything, to being so depressed, to being so down, to being so, sad that they can't even, they can't even get out of bed. They can't even, comprehend, life. They're feeling very hopeless about life. And this, as one of my patients used to say, she's 16, used to say that is very, it's very bad for her because of the fact that she cannot control her emotion. So this is not something that you can control. She was like, I feel like I'm being controlled by something else, not being able to, control being sad, not being able to control, all this, 1 minute she can feel very happy talking to family, talking to friends. And the next minute, she can be very down. She's not trying to, talk to anybody. She's not trying to do anything like that. So when that usually happens in that aspect, but bipolar is also we have bipolar 1 and we also have bipolar 2. I just said bipolar disorder, just to, I think mostly when I'm talking about this is talking about bipolar 2. But bipolar 1 is usually when you have also had some kind of a psychotic incident or a psychotic break, or you've been hospitalized because of something that, is going on. So that is also one of the things that usually, if we ask you all these questionnaires, about have you felt, happy? Have you felt, sad? Have you felt that, you can do everything? Have you felt, and so we ask all these questions. The difference between the diagnosis of bipolar 1 and 2 is that have you been hospitalized, in the last 3 months, in the last 6 months, in the last year? And so bipolar disorder is basically, swinging from one mood to the other, where you cannot really control much of what is going on. Next slide, please. And some of the signs and symptoms of bipolar can actually, you can stay right here, can actually be, some of the symptoms of depression and some of the symptoms of anxiety kind of like mixed together. Sometimes people, can have all those kind of symptoms. So that's why we have specific screening tools to be able to decipher if what you're having or if the symptoms that is going on right now is depression, is it anxiety, or is it bipolar? Unfortunately, some of the things that sometimes people don't get diagnosed earlier with bipolar is because most of the symptoms either comes out initially as depression or as anxiety. So as you get treated further, then sometimes bipolar disorder can be identified, because either through questionnaire or medications that you've been started on, different symptoms could be triggered. Schizophrenia is another disorder that usually we treat in our mental health, umbrella. Is that schizophrenia, I will usually say it is, I usually, like on this slide, I said, positive and negative symptoms in such a way that schizophrenia, as all mental health disorders, doesn't have any one specific cause, and just like, Brother Eric said, and mostly all of our mental health disorders usually does not have any one specific cause. And I think I've heard Brother Eric and Sister Mercy talk about, social aspect, genetics, environmental, and all these other things that they all can come together to do this. So sometimes too, when we talk about, diagnosing you with schizophrenia, I have put it into two different, symptom categories, which is the positive symptoms and the negative symptoms. And those are all symptoms that is not really good, but for us practitioners, we will rather somebody have the positive symptoms rather than the negative symptoms. So the positive symptoms are like the delusions, the hallucinations, they're seeing things, they're hearing things, disorganized behavior, confused thoughts, their thoughts, they can't really ascertain what is normal for them, what is reality versus what is, non-reality. Sometimes people lose touch of what reality is for them. So sometimes when you see people talking to each other, talking to themselves, to them, they are seeing somebody that they're talking to. And, as one time I was with, my patient in our office with the door closed, and he's telling me that, the person that he talks to is right there in the room. I didn't know whether to be afraid or to run, because I'm like, it's just me and you in this room, I don't see anybody else. But he was like, oh yeah, describing him and everything. He's right there. Is he? So then I'm like, well, is he nice or is he not nice? Because, these are one of the things that sometimes, it becomes a problem, that these voices that they hear, these people that they see, influence their thinking and their, what they need to do. Is this person a nice person? Are they telling you to do nice things, or are they telling you to do, bad things? Are they telling you to go kill somebody? Are they telling you to, go, and all these things, it's real to them. It is real to them. I'm not seeing it, I'm not hearing it, but they are hearing it. And this is, what I talk about, the brain. The brain is such a powerful thing that we have going on. Sometimes I wish, there are different ways that we can study the brain without, somebody being dead before we can, do more about this, because it's a powerful thing, because they're seeing things. I had a patient I was treating with schizophrenia, and he specifically asked that he didn't want to stop hearing these thoughts because the person that he was talking to was very nice. This person encouraged him. He, said nice things about him, because some of our psychotropic medications, some of the medications that we give them, silences the voice, you hearing voices and all these things. And he did not want to stop hearing that particular voice, because that particular voice was encouraging to him, helps him throughout his day. When he goes to school and he's not, really engaging and having friends and stuff, that voice, encourages him and all that stuff. But for other people, when that voice is trying to tell you to do bad things, then we need to be able to control that voice, and not, because then to them it overshadows their thinking, and all they can hear is that voice. And so that comes with, either hearing, seeing, both, confused thought and all that. As the negative symptoms is actually when it becomes really bad, that they have slow movement, like they have changes in sleep, they have, poor grooming, they have blunted affect. So it's like when someone is telling you, oh, my dad died, and they're like, they're laughing, or, you can't really tell by their facial expression when they say something that is sad. Their expression doesn't go with what they're saying, or it's, the opposite of what they're saying. They're laughing about someone dying, or they're, sad about. So it's like their emotion and their facial expression is not congruent. And when someone has that blunted affect, you can't really tell anything. And their voice is like really monotone. When they're talking to you, there is like, they're expressionless. And that is usually not a good sign for us, when you're in the mental health care world. That can lead to so many other medical problems for some of these, patients, not being able to move, because sometimes people get to a point where they cannot even move their entire body. And it's almost like now they're having medical issues because they've been laying in bed, for so many days, or they haven't slept for so many days, or, they're poor grooming and all these things that is going on. And schizophrenia is, and just like all of the mental health issues that we're talking about, and I think in the beginning, Sister Mercy said something about the depression. It is something that can be a chronic situation. Usually I tell my patients that, when you have a diagnosis of depression, and you have that diagnosis and you were treated and now you're feeling better, it doesn't mean that the depression goes away. Part of, one of the things that, we also have different things like the seasonal affective disorder. So there are things that can come and go, and there are things that are chronic. But I always tell my patients that, because some of them usually will come back to me in a year or two, because now, they were feeling better before because they were taking their medication and they thought they were feeling better. So they stopped taking their medication or they stopped going to therapy. And now it's been 2 years and a lot of things have happened in life. And now they are back down to, before, needing, support again, feeling depressed again, feeling, anxious again, because they felt better. So I always tell them that, being on medication or seeing your therapist is almost like, having a straight line and always having something there to support you. You always have, once you've been diagnosed with depression or anxiety, you always have that underlying thing going on. It is always there, but it depends on how you handle it and how you follow through with your therapy or with your medication, because the moment you stop those things, life keeps coming at you, and then you might lose the resources that was given to you, and the medications that was given to you or the therapy that was supporting you in being able to, manage these things. Next slide, please. So I think I'm gonna, Mercy, you can jump in here with treatments for different types of this mental health. And we just put them together here as psychotherapy and pharmacotherapy because, it goes hand in hand, talking and medication. And I will also actually add it here is prayer. Most times I educate, our patients, I always ask that question about their religious background, because not all patients are Christians. Some of them have different religious backgrounds. So part of the initial assessment is to find out where they stand when it comes to, religion. Are they Christians? Are they Buddhists? Are they, so I always, let my Christian patients know that, just like you take your medications and pray and, do everything else that you can do, because, for us and where we come from and different things, there could be a demonic connotation in, what is happening to you, because the enemy knows, and any way that they can use to, attack you, they will. So if you're praying, then if it's a demonic aspect, that would take care of that. If you're taking your medication and it's a brain, brain to behavioral aspect, so we are covering all our bases. So Sister Mercy, go ahead for me.
Alrighty. So the debate when it comes to the psychotherapy is essentially talk therapy. But I want to talk about just because she just finished schizophrenia, because when someone is having the negative symptoms and the positive symptoms, it's a little bit difficult for them to follow the basic talk therapy. And so a lot of when someone is struggling with those schizophrenia symptoms, we do in addition to the medication is helping them with that routine. And I don't know, I think everywhere, but at least in New York, when I worked most of the time, we had something called PROS, and it's a day program where they will go and they have activities for them. So as they take their medicine and they have that routine, things going on, providing that support, being part of a group, those are the things that can help someone that is having very active symptoms of schizophrenia. But we're going to spend a lot of time on depression, anxiety, PTSD. Those talk therapy is excellent. People can very much engage in it. So when it comes to talk therapy, there are multiple modalities that people use, but the most basic and common one for especially depression and anxiety is the CBT, or cognitive behavioral therapy, or the interpersonal therapy. So CBT is when you allow the person, you help the person to learn how to recognize and change their thought patterns and change their behavior. So for example, when someone is struggling with a lot of anxiety, sometimes my patients would tell me, I don't understand why I'm feeling anxious. Or I'm feeling depressed. I have a lot of good things going on in my life, but it's just sometimes it comes out of nowhere. And so when it comes to the CBT, we do something called cognitive restructuring. So if your thoughts are extremely irrational, when someone is having a lot of anxiety, they catastrophize everything. So I went to church, and Auntie Sewa looked at me in this negative way. She thinks I'm doing this, I'm doing that. And you can come up with a host of things that you think somebody else is thinking about you or why this is happening. And so that leads to all these anxiety symptoms and all these depressive symptoms. And so we will use the cognitive behavior, cognitive restructuring. We will talk about, okay, yes, she looked at you this way. Well, why don't we talk about the reality? What really could be the case? Could it really be that she's probably looking at somebody else? Or could it really be that it has nothing to do with you? So CBT will just help you restructure your thought process. If you're having a lot of negative thoughts, I am the worst person in the world, I don't amount to anything, I have really low self-esteem, I'm a burden. Or we don't dispute that. I hear you. You may be a burden. However, why don't we identify the positive things about you? I like practical examples, and I hope that helps. That helps me. I have a patient that I did last month, and she has a lot of physical disabilities. She's a single parent of 3 kids. She is getting disability, which is not enough. She's not able to work because of all the pain. And so I spoke to her, and she said, "I feel like I'm a failure. I'm not doing this." And I said, "Great. Yeah, you may feel like a failure because yes, of course, society, the idea is that you go to work, you provide for your kids. However, are you and your kids homeless? No. You can't do 9 to 5, but you're doing DoorDash to help with your disability money. You've raised wonderful kids. Your kids are doing really well. You did something right." And so we worked on, let's identify those positive things about yourself, those great things about yourself. So CBT uses a lot of worksheet. So you will have, when you go to see your therapist, they'll give you homework, they'll give you a piece of paper, and it will have identify those positive things about yourself, positives to help bring out those good things about you. Let's restructure your thought process. So that's CBT, a lot of talking and using positive ways to help you look at things in a different manner. We also have the interpersonal therapy. So we are like acknowledging those, essentially CBT, right? Acknowledging those things that help you to restructure your thought process, do things differently to help you see things. I one of the things that I love, especially with our teens, is journaling. Journaling is a key. If you're having a really difficult time with the sadness and the depressed mood and the negative thoughts about yourself and the anxiety, put your thoughts on paper, put it down, write it down. So if we bring it to our level, if you're at church and you're having all these trouble and you're not in therapy yet, I think one of our kids and I had this encounter. I got her a journal. Okay, I need you to write anything that comes to mind. Tell me about your day. How did your day go? Put it on paper. Find somebody in a church that can acknowledge your feelings and not dismiss how you feel. We as Ghanaians, we don't do a really good job. When someone comes to you to tell you something, you make it seem like it's no big deal. As Sister Dilla said, there's no problem. So why are you feeling this way? That doesn't help. We acknowledge, it is how you're feeling, acknowledge it, validate how you're feeling, and then let's talk about how we can get you to get better. So these are the basic things that we can do at home until we get them into psychotherapy where they can do CBT and then get the medication. So Sister Dulles, you can take the
Mr. Dulles, before you come in, I just wanted to add just a little bit to that psychotherapy piece. For example, when we go to church, and then we have incorporated what our older generation used to call a Pentecostal for and that we do adoration moments where we help our kids to adore God and sing some worship songs, we call it adoration songs, and help them meditate on how great God is. That impact is a meditation piece that part of psychotherapy we teach. We help patients, we help clients to practice mindfulness when they're going through that therapeutic process. We do this most of the time in our churches, but because we are not mindful of it, we don't value that therapeutic process. So as JOA leaders, I believe and hope that if we team up with our our team or mental health teams will be able to help our kids more realize that when you come to church, these are some of the things you do to help ease some of this whole, uneasy feelings that you feel. Sister Dallas, you can continue on. Thank you.
Thank you. Yeah, that is powerful to know that. Okay. And so usually in my practice, so I work hand in hand with our social workers and our psychologists. And usually when patients come to see me is from a referral from, the psychotherapy department. And it's because psychotherapy is not helping and they think that we need some kind of a medication to help with that. And sometimes I also refer patients to psychotherapy. Medications is not, usually when I evaluate a patient who has, anxiety or depression, medication is not my first go-to, especially if it's your first time experiencing these things, because sometimes it could be something that you can talk through, it and be able to identify the causes of what is making you feel the way you're feeling, and be able to handle it with, with consistent and frequent therapy. Sometimes people do 2 to 3 times a week. Others, do 2 times a week, once a week, all of that. So when we initially come on, I usually talk to the patients. If it's something that you've been dealing with for many years and now you're seeking help, of course, it's overwhelming you. So we need to get in some medications to help stabilize everything. If it's something that is initially coming on, just like I said, I will refer you to someone who would be able to talk to you and see if the talk therapy can actually help you with that. So there's a lot of stigma about mental health and also mental health disorder. I think we've even come as far as to use the word mental health. I wish we can all use more like a neuropsychiatry in a way, or I don't know. I think we need to come up with better naming for this, and especially the medications that, we use for our patients. Because when I talk to a patient about using an antipsychotic, guess what? The first thing, I'm not psychotic, I'm not crazy, I'm not this. Yes, so I wish, we can all try to rename and rechange, a lot of these things, because there's a lot of stigma, there's a lot of negative thinking when we come to talking about, mental health disorders, or when we come to talking about depression. But this is the health of your brain, the health of your mind. Just like we take care of our body, we need to take care of our mind. But we've come a long way. Just like I was saying, we've come a long way to thinking about these things. So different types of medications that we have for our patients. Of course, we have the antidepressants, which, the name antidepressant is supposed to anti your depression. Anti-anxiety, sorry, anti-anxiety, is supposed to work with that. We have antipsychotics, and that is also, a form of medications that we use. We also have, sleeping pills, and we have lithium and other mood stabilizers. Okay, so we have a lot of different types. If I even say antidepressant medications, we have a lot of different types of antidepressants and anti-anxiety. And I tell my patients that, unfortunately, I cannot look at you with your diagnosis of depression and just say that, okay, you know what, you will, Prozac will benefit you. So with an antidepressant, we do have different types, and I don't want to, bug you with all of that, but, we have the SSRIs, the SNRIs, there are different types of medication. One of the things that, I want you to take away from is the fact that when you are talking to somebody like that, they will at least educate you about the different types of medications. And when I also am talking to people about starting medications for them, I do ask them if they have any other family members, because remember, genetics can also play a part in this, do you have any family members, close family, mom, dad, siblings who are on any type of antidepressant? Have they heard of any type of antidepressant, any type of anti-anxiety, any type of these things? If they've heard, if they haven't, then, you educate them about, these medications. I also let my patients know that there's a lot of them out there, and I don't know which one will work for them until we try. One of the other things too that I tell them, because, most people don't like taking medications, I'll have to let you know that, once you start taking it, there are some medications that you might need to do a blood work so we can check your, your liver functions and all these things, cholesterol and all of that, to be able to make sure that everything is fine, because it can increase or decrease some things, in your body. I will let them know. One of the good things that sometimes I say to my patient, majority of the antidepressants that we use is metabolized in your, in your gut. You pee it out, you poop it out, and, it kind of gets out of your system. You drink a lot of water, you clear it out. It does not metabolize through your liver, where it can, stay much longer, or maybe even cause, a lot of damage, to your liver. But with these things, so usually I tell them when they're hesitant about trying different things, because sometimes I tell them you have to try and fail for me to know that this does not work for you. Of course, when it comes to medication, we also have this new testing called gene site testing. Now, gene site testing is not covered by insurance companies. I think maybe we're trying to work on Medicare and probably Medicaid too. So gene site testing is they draw your blood, or sometimes they swab your cheeks, depending on who you go through, and they're able to look at different genes in your body to be able to say that, okay, with all of these medications over here, this type of antidepressant will work better for you because we've identified these things in your genes, or these type of antidepressants will work for you, these type of so there are that can be done. And I only ask patients who we have tried different things on that has not helped them and they're still having symptoms, for them to get that gene site testing done, so we can eliminate a lot of, this. Clinical wise, it helps a little bit, but it doesn't help too much, because once we find out that one group of medication is not helping, all the medications under that group is not helping. But if we have a patient who has struggled a lot of years, they've tried different medication and it's not helping, then the gene site testing can kind of give us a little bit of insight as to, different genes and different, DNA strands that have been pulled to say that, you will not benefit from this type of, antidepressant, or from this type of, antipsychotics. But most of the time when we have to start you on medications is because you have gotten to the point where your mindset and the therapy that has been going on is not helping you. So we need to give you some medications to help the mind, to help all the neurotransmitters that are kind of going wonky in your system to normalize, so that you can, feel better, you can, sleep better, you can, function properly. So we have the antidepressants, we have the anti-anxieties. We educate everybody about that. And we make sure that you always follow what your doctor asks you. So if I tell you, if we start the medication, it's 20 milligrams a day, please take your 20 milligrams once a day. And, if you have any reaction to your medications, please let your doctor know. And one of the things that I teach them is that I give them the regular adverse reaction, which is common because, like stomach irritation, stomach pain, nausea, those kind of things are very common. Abdominal pain, constipation, or diarrhea, or, those are very common. If it is going on and you can tolerate it, if you're nauseous and the nausea is not like overwhelming you, it's something that kind of comes and goes, well, let's push through, drink some ginger ale and try to get the medication going. Most antidepressants, anti-anxiety Well, let me just, antidepressants, it takes usually a good 6 to 8 weeks to really get in your system and start working. So it's not something that, so that's one thing that I also have my patients understand, that this is not a magic pill. It's not going to start working right away. When it comes to anti-anxiety, though, we do have a group of medication called the benzodiazepines. The benzodiazepines, maybe most of you guys have heard Valium or Xanax, or, those things, they work, they're short acting, they work quickly. But for us practitioners, that's not my first go-to, because it's almost like a Band-Aid. You put a Band-Aid on something, it will take away your anxiety. It will make you feel better, but the underlying problem is still kind of like there. So for me, I would rather put you on something that is more long acting. So I'd rather put you on an anti-anxiety, non-benzodiazepine, so that it will give you a longer, pronounced. And that is something that I always tell my patients. I wish most of our primary care providers can get more into, which, I mean, it's not their specialty, so I get that. But a lot of my patients come to me and their primary doctors have already prescribed them some Valium, or they've already prescribed them some Xanax. So to them, it's like, well, they gave me this and it worked. So now they're not even willing to try anything, of that sort. But we really talk to them about making sure that we're not taking these the easy road out, because it's just a Band-Aid that is not really helping the actual cause of things. We also have, antipsychotics, as I said, and mood stabilizers. So we're basically trying to stabilize your mood. Antipsychotic, we're trying to kind of like, the voices that you're hearing, the things that you're seeing, we're trying to help so that it doesn't interfere with your normal activity. Can you imagine, sitting in class trying to, listen to your teacher and someone is talking in your ears? Very distracting. You cannot pay attention to what is going on because someone is in your ears, saying something, or sitting in class trying to listen and there's, that person that you're seeing standing next to your teacher. Depending on what they're doing, you might just get, you might get distracted and all these things that is going on. So we use these different types of medications to help manage the symptoms. Most of all these medications are symptom management, and unfortunately, when some people ask me, so this is an antidepressant, am I going to be on it for the rest of my life? I can tell you right here, right now, as we're sitting here, to tell you whether you will be on it, for the rest of your life. But I know that once we start the treatment with antidepressants, at least a year of you not having any of these symptoms, being on these medications, then we can talk about, depending on what you're taking, do we need to come down on it? I usually don't like to take people off of these medications because, eventually it will come back, but it's also a preference. When it comes to these things, it's about talking to your patient and listening to them. It's not one size fits all. It's about talking one-on-one with this person and getting to know them and getting to tell them what is really important to them. So one of the things that, I just wanted to take from here is education about these types of medications. And then also you can find some of these things yourself. Of course, nowadays we have all these search engines and, Googles and Bings and all of that stuff. I usually tell people that always look for the scholarly papers that are on Google. Don't try to go to, WebMD or, some of these other websites that will just give you a whole bunch of information. And then it really, will stress you out. But even if you get a whole bunch of this information, bring it up to your doctor and ask about it. I just always encourage people to, also seek out your own information, but then bring it to us so we can talk about it, because we need to know what pertains to you. Whoever is writing these things or people have been talking about these things, It's just a matter of what they have experienced. Everybody, literally everybody, every person is different in how they metabolize. I can take Prozac and it will work for me. You would take Prozac and it will not work for you, but there is something that will work for you. So seek your own information, but bring it to the table and ask questions. Talk to your doctors, ask them questions. Do not be afraid. They are there for you. It's not the other way around. We are not there. We are here for you. So do not be afraid to ask your doctors questions about your health. That is very important. Next slide.
I want to add something real quick about, so there's a program called Collaborative Care, and that's actually the company, something that I do, and where you go to your primary doctors, and we're all over the states. You go to your primary doctor, and the questionnaire that Brother Eric had brought about, the GAD, to check for anxiety and depression, and your doctor will do this, and if you're having these symptoms, they can refer you to a program like ours, where you come in, our psychiatrist will give your doctor guidelines to give you medication, and you will have a therapist to talk to over the phone. So don't be hesitant to talk to your primary doctor. And even us ladies, the OBGYN, we're working with them. So if you go to your OBGYN, you're having these symptoms, you let them know, they can refer you out and have somebody give you this support as well. So just something to add in addition.
All right. Thank you so much. I promise this is going to be the last version of this. It is very, very comprehensive, but we just being mindful of the time. Substance use disorder, I can guarantee you that this is a whole presentation on its own, but we will do as much as we can to make it brief but essential, so that we can help ourselves, our family, and most importantly, the junior youth that we work with. Substance use disorder, we call it also drug addiction. This is a clinical way and a very modest way of not really reducing the stigma attached to this drug addiction. I'm an addict and all those terminologies. We call it substance use disorder. There's a substance use version where one uses illicit substances or illicit drugs or prescribed drugs, and that's a substance use. But at some point, it becomes addictive. And when that happens, it interferes with the way our brain chemistry functions, and it leads to repetitive drug-seeking behaviors. So addiction is defined as a chronic relapsing disorder, which is characterized by compulsive drug seeking use. And despite the consequences, you know that this is definitely going to hurt me, or the consequences of it will impact me in a very negative way. It's detrimental, but yet my brain is telling me to go and seek it and get it and use it. So I'll go for that. So it is considered a brain disorder because research has revealed that it involves altering the functional, it alters the brain, how the brain circuits response to this use, and the rewards we get from using it, and the stress and the self-control, and how we're able to manage it. So even when someone goes through treatment, after the treatment, it takes a while before the person can fully be, we can say, fully recovered. But the recovering is always a process and is an ongoing. So, for our young generation, are faced with so many challenges that we think they may not be working. So we think and those kind of things. Yes, these kids face through a lot. The challenges from social media, the expectations we have for them, because there's a vast availability of resources and things out there. So we expect them to do to operate or function to certain expectation, and that could put a lot of stress on our children. And some of them can rather go in order to keep up with all those demands, they start using drugs. And before we talk about some of the long list, and I'll try and mention quite a few, some of the examples of them, I want us to take a good look at some of the signs of drug addiction. I have it in 3 different categories, even though we've lumped it in one. The physical signs of substance use disorder, sudden weight loss or gain, pupils that are smaller or larger than usual when they are dilated, when there's a bloodshot, redness of the eye, changes in appetite, sleeping patterns, slurred speech, impaired coordination or tremors, deterioration of physical appearance or changes in grooming practices, running nose, secretive behavior. That we will come to that part. Now, the psychological part is the feeling of paranoia, anxious, fearful. When you have these kids who are behaving that way, we want to be mindful and trying to see if we can engage them and get to understand what they may be going through. Some of the other psychological factors will be unexplained changes in personality, feeling spaced out, lack of motivation, feeling excessively tired or having a lot of energy, sudden changes in mood, increase in agitation. These are signs that psychologically we can observe in our junior youth, our children, our family members, or even ourselves when somebody start using. Now, behavioral signs beginning to act in a very secretive and suspicious way. You have a kid or junior youth member who's acting so secretive. When they're experiencing problems in relationships due to conditions like that, they using more than originally intended, like a prescribed medication, they will use more than that. They neglect family and friendship responsibilities. They're getting into legal problems, driving under the influence and all that. So these are some of the behavioral problems that we should be very mindful of. Compulsive eating and frequent hunger, fatigue, hyperactivity, wearing inappropriate clothing, and all those things. When they start stealing, a kid whom you've known through your entire life, not knowing to be stealing, all of a sudden starts to steal because they are becoming very, that's an addictive behavior where they desperately need that. So let's look at some of the very common drugs that, even though alcohol is one of the things we don't normally add to be part of a drug, it is a drug. And alcohol use disorder is something that is harming a lot of our generation. People drink alcohol when they are sad. People drink alcohol when they want to be happy. And it has so many effects. Alcohol, as a matter of fact, is a depressant. It causes depression at the end of the day. It affects our brain, a part of the brain that will have us feel depressed. So there is a delirium also where, our youth could be using that, like they'll be experiencing when they start drinking alcohol. The other thing is nicotine, which is cigarette. This is an environment where our children are growing up, and cigarettes or nicotine use is becoming like a norm, and it's harming our generation very much. So the best, I know that Sister Dillis and I will touch base a little bit on the treatment version, but I can say that the best and more than 100% effective way of treatment of drug use is prevention. If you're able to catch our kids on time, help them through their stress, help them deal with the stress, and not result to using any form of chemical to help manage whatever they're experiencing, that is the best way to prevent that. So tobacco use, nicotine. I do see some ministers who are not Ghanaian, non-Ghanaian ministers, or so for now, on the call, I know Jinana, sorry, no cigarettes. Wow. Doctor, now appear could now one thing, why is stressed out? No cigarette. So I'm asking myself, wow, this is very concerning. So our kids are exposed to this environment and addiction to tobacco because of the nicotine content. It stimulates their dopamine neurons, and it makes them feel this feeling of relief. So this stress that our kids go through can potentially lead them to using some of these drugs. Another type of drug that is now taking over the world is marijuana, weed. On the street, they call it pot. They call it ganja, cannabis, so many different names. Our young junior youth members, and now it's been legalized in most of the state because there's a content of it that used in managing nausea and pains and all these things. But there's a long-term effect when these kids are exposed to it. It could be addictive, and it can potentially cause so many problems. Like I said, for the sake of time, we won't be able to go so much into it, but let us be mindful that marijuana is out there. And some of the things that our kids, that can potentially expose our kids to, is because they feel like, if I use any of these drugs, it makes me feel cool. It makes me feel belonged, peer pressure. It makes me ability to stay focused and study well because we have high expectation of them. My friends are using it. It makes me feel so happy, feel sedated, so I can have fun right now and use it. And these things are really, really causing so many problems. The other aspect of it that overwhelmingly is out there is the opioid use disorder. We have morphine, we have heroin, we have codeine. These are all synthetic sedative, drugs out there. Oxycodones that may have been prescribed. I'm not going to say Sister Dillis might prescribe oxycodone to a patient who comes in and say, I'm feeling pain, and expect that this is going to be an ongoing thing, because she knows very well that this is can potentially be very, very addictive. So if you have any junior youth member or a parent who is prescribed any of these medications, please just watch out, be mindful, educate them. And if it is getting to that point, let's start a conversation with them so we can help them out, please. Heroin is killing, especially if you come to Baltimore, where I work. Maryland is killing so many people, those who are getting overdosed because of that. Stimulants is also some of the medications out there, amphetamines. For these medications are there, and our kids are faced with the temptation of being exposed and being asked to try, and curiosity. So in fact, we've exhausted a lot of time. So I don't want us to go so much on the long list of the medications. We can find another time, probably also dive more into that again. But I want to call our attention that there are treatments that are available for any of our kids who have been exposed to this and are struggling with addiction. So together in our world, some of our world, we've started adapting the terminology behavioral health, Sister Dillis, so it'll be a little bit less stigmatized, behavioral health, because the use of medication and addiction part affects and brings mental health issues. So it affects our behavior psychologically, medically, and so many others. So to modify that, we call it behavioral health. So psychotherapy also helps a lot when our kids engage in group and individual sessions, or even individuals. Anyone who is struggling with addiction can be referred into these programs, where we have the inpatient, where they go for either detox or stay there for about 30 days for residential. They engage in groups, help them, motivate them so that they can stay out of the environment that are triggers to them wanting to use. And the young leaders are, we want to create an atmosphere where our kids can talk to us more about that, so we can have them feel comfortable and we can motivate them to stay away from it. The outpatient ones, and then so they are there. The pharmacotherapy version, I will leave it for Sister Dillis to give us a little brief presentation on that, so we can move forward to do a discussion or any questions and answers that will follow.
Yeah, and I'm just gonna be real quick about the pharmacotherapy. Sometimes people are like, well, the person is on drugs, why are you adding more drugs? It's just lesser, I guess we can look at it as the lesser evil of everything else that is going on. So if they're on heroin, or if they're on medications like that, it will be good to put them on a medication like buprenorphine, which is like a lesser version of that, because it hits the same areas in your brain that when the heroin goes, it hits. So these medications are prescribed and you are under a doctor's, or a nurse practitioner's supervision. You're doing drug testing, so to be on these medications, it's not just like you come on in and, someone starts you on medications. We assess you, we drug test you, we start you on these medication with the hope that as we give you this medicine, your body will not crave the heroin again. And as we slowly taper you off of the medicine. So the ideal is usually to bring you from doing heroin to a prescribed, medication, and to slowly taper you, to taper you down and eventually off. And this is usually a group effort. So is medication management with, psychotherapy, with the group and individual session, with whether in an outpatient or a residential facility. And we can go to the next slide.
Okay, so we've spent a lot of time, we've spoken about a lot of information. Let's bring it to our level. As a JY leader, you have a child that comes to church every Sunday and you see some of these symptoms that we've mentioned. I know it was a lot of information. You can reach out and we can give you more, condense information. So if you see the child is withdrawn and all these things, engage them, reach out to them, talk to them, make them know that you are there. They can text you, they can call you. And when they come to you, be non-judgmental. Non-punitive. If you're asking them to present something in a church and they're not able to do it, don't be frustrated with them. Don't be punitive. After church, reach out. Something may be going on. And so I think also as JY leaders, maybe we need to allow the kids to know that they can come to us no matter what. If you have a child that is able to open up to you and say that I want to talk to you about something, that's golden. Take that, acknowledge that, let them know that thank you for feeling you can talk to me. And let them know that everything that we talk about is between us. However, because it is a church level, as you talk to them and you get to know what the problem is, let them know that you have to get their parents involved. And what that looks like is that, and I am big on lesson learned. When I do something wrong, how can I learn from it? I had a situation like that, and I think I thought I was and being with my profession, I was able to handle it. But at some point, I needed to get the parents involved. And I think what I didn't do first was to educate the parents before. And so if you see a child that is struggling, it will be very helpful to educate the parents about what's going on. And if you need our help, you can reach out to any of us. We can help you educate the parents. So you let them know that this is the problem and see how we can all help the child together. When you let them know that I will keep your confidence. However, if it's more dire, if you want to hurt yourself, you have a plan, all these things, then it needs to be escalated up. And so just leaving that open door policy, letting them know they can reach out to you. And if they come and the situation is harder for you to handle, then reach out to myself, Brother Eric, Sister Dillis. We can guide you. Now, every state has resources and every state has how they go about things. So I can share with you Maryland and New York, or even help figure out where to go to get the help. The general nationwide suicide prevention hotline is the 988 number. It's a text you can call. There's always somebody online to talk to you. There's always somebody there to listen to you. And there are clinicians, there are professionals to talk to you about that. So as leaders, it's really important that we let the kids know that they can come to us. And when they come to us and we feel like it is too much for us to handle, reach out to any of us and we will be more than happy to provide the support. And I saw some of our ministers online. It goes for us too, as our papanum and our mamanum. We really plead that if a child is able to come to you, I am anyone that knows me personally know that I am big on prayer and things of God. I don't dismiss those things. However, it is important that we need to realize that as we treat the spiritual aspect of it, we also need to add the talking piece and the medication. So if a child comes to you and you pray with them, please don't let them just go. Find any of us. I've lived in New York. I was in the youth for many years. So anybody that been around knows me, knows Sister Dillis. They can reach out to you. Can have them reach out to us, and we can please provide the support. When the kid comes, please don't dismiss them. This is really important. Don't dismiss and let them go and make it seem like it's not important. It is, and we may lose some of our kids. Some of our kids are using, on
Yes.
Facebook, the TikTok, the Snapchat, they're selling drugs on there, and some of our kids are using marijuana. You may not know, but it is happening.
Yes.
Let us please not dismiss it. It is really important. Let's take a note and do something about it. Thank you so much.
Thank you. So now, just like we're all saying, we've given you guys a lot of information. I don't know, I think maybe Brother Noble, I don't know if you can, if someone has questions, you can coordinate that and let us know. So I think maybe we can start with C, since in the beginning she had something to say. So let's open up the floor for all. Thank you.
Hi guys, lovely to be in your lovely midst. Pardon? Oh yeah,
Sorry,
hi guys.
Let's go ahead. Go ahead. Yeah.
So I had a few observations. Number one, mental health. Everybody's got mental health because everybody's got a brain. So it's nothing to be ashamed of because everybody goes through stresses and everyone's got a brain in it. So obviously mental health is there. Also, autism and ADHD is not a mental health issue. And I think it's very dangerous to portray that picture, especially with the youth. ADHD, it's not a bad thing in it. You just can't sit down, you can't concentrate. Get a stress ball, draw flowers, like there's solutions. Or being autistic as well, there's nothing wrong with that. It just means you're just more cleverer. And like both of them are one of the same. So I think it's a very dangerous narrative to put out there that it's a mental health issue because it's actually not. Also, therapy, just because you go to therapy doesn't mean that you've got mental health issues in it. It's just good to talk to a professional, and it's just helpful just to chat to somebody that's outside your normal circle and that can look at your situation impartially. So I also think that's a good thing. And just to like Eric, you said about like people smoke weed, butter spliff, to be cool. I don't think anybody sits there and buns to get cool in it. Like it's not that. Do you see what I mean? And sometimes, it's just enjoyable. Let's be real in it. So, but it's not godly, but it's enjoyable. And like herbs are grown. I'm not saying it's something that people should do, but I think that narrative of like, oh, if you smoke weed, if you sell drugs, if you're a bad youth, you're not a bad youth. Like anyone can change their life in it, and don't feel ashamed. The fact that you need to do better, speak up in it, because obviously like stuff happens in it. It happens. And we've all been there. So just know that there's older people that you can chat to. Do you know what I mean? And really and truly, no one, should be selling drugs. That's not cute. That's disgusting behavior. Because if you go to prison, your parents are going to be very upset. So selling drugs is just like a no-no. If you want a bun, I hear that. But selling drugs, I'm just not for it in it. Unless I can assist any further, guys. Those would be my submissions.
Thank you. And, I'm just gonna, it's, like the drug situation has gotten so bad in the last maybe few years.
But sorry, can I ask you a question for that? How, as adults, yeah, and elders within the church, yeah, youth are selling and nobody's doing anything about it. Like how? How did you come to know that information and no one done anything about that? Because that's wild to me, isn't it? That is
they're using. We don't know if they're selling, but
okay, because I thought I heard that. That's not cute.
No, it's the using part of things. And I was actually, they're using vaping, different things, including marijuana.
Vaping, sorry, I just want to put this out there as well. Vaping's become like a new craze, but I don't think what people realize is one vape, is equivalent to 20 cigarettes, one vape. So I don't know about America now, but they're about to like delegalize it because it's just a disgusting habit in it. Obviously it happens in it. I hear that. But I think people think it's like shisha. Shisha's not good for you either. In the grand scheme of things, smoking weed, is actually better than cigarettes, vapes, and shisha. But obviously there's that narrative out there that because it's illegal, it's they're all just as bad as each other. So you can't cherry pick what you want to say in it. Like it's just as bad. Alcohol is a disgusting thing. Because people get drunk and they act a fool and then they don't remember the next day. No, because honestly, I stopped drinking, because it's just, you get depressed and you get emotional in it. And we're all like, we're emotional people. That's how people get into fights. That's how things happen in it, because you're drunk or you drink too much. So that's not even cute in the first place. But vaping, let's be honest, it's out there now. And I don't think it's a good thing. But if you started doing it, cut it down, because you can't just stop doing it. But it's not cute. It doesn't look cool. It's not cool. It's not even sexy, bro. So obviously nobody wants to do that. So you just pattern yourself slowly but surely. You stop it, innit? And like just chewing up.
Thank you. See, that was a very. Let me say this. Someone Abena sent. I believe Abena might be at work. It's a great presentation. Thank you so very much for sharing. Just a little addition. Research shows that spending time with nature, trees, and green spaces can help improve moods, lower blood pressure, and reduce stress. So let's take advantage of these trees, parks, and gardens around us to support our mental health. Thank you, Sister Abena. The destiny is open now for people who want to ask questions. Please do that now.
Let me, so for the purpose, of our platform and media, or our audience, yes, all sorts of substances used are not accepted for us in this setting, right? So, marijuana, all those things. Yes, there are a lot of research out there, that will tell you, marijuana is better than this, or, this is better than that, that is all out there. But for our purposes, marijuana smoking is not, it's not accepted here. And especially for the JY, because your brain is not fully developed and you don't want any other thing to, to do that. But I was going to say that, now they're really cracking down on substance use and abuse and people who actually share with their friends. I know there was a case out here in California where someone who shared some kind of something laced with fentanyl, he shared it with somebody else. The person ended up dying and he passed out. And when he woke up with them, the person had died next to him. He did call 911 and everything, but he just got sentenced to 15 years to life for actually, being with this person and actually, given, which, there's a whole lot of controversy on that because, you came, you wanted it, I shared with you. So really you took it, but they're putting the responsibility on the person that shared it, and yesterday as I heard the sentence and I'm sitting down and I'm like, oh my goodness, this is a disease. Like this person who shared it with the other person, he has a disease that, his brain is telling him, even though this is wrong, this is what I need, this is what I want. And so he did it with the other person. So now the entire United States is cracking down because substance use and abuse is just overwhelming. So now they are cracking down on so many, just even the littlest thing. So let us be mindful of that. As JYs, your brain is still growing. You don't want any other substance to come in and suppress your brain growth. Any more questions, please?
I just want to add something that
yes.
We know our kids are challenged, our young youth especially, and I believe that's the major reason why we are helping our JY leaders to be mindful of this. There are some behaviors that once it's started, once you get addicted, you cannot, it's difficult to manage it or to control, to stop. And our purpose for today's presentation is to help us all equip ourselves to help educate and call awareness on our kids to not start that behavior. So any chemical, if it's not prescribed by your doctor, should not be encouraged.
Noble, you're muted.
Thank you very much. Thank you very much. Amber Lorraine says very informative section. God bless you, health workers or health professionals. Thank you very much for the good information given to us. Please, the floor is open for more questions. If you have anything on your mind, you can ask so that we bring or we draw the curtains down.
I think someone had a question here. Said, I'm curious about the genetic aspect of all this. How can some genes / people be more prone to mental health disorders than others? That is so true. That is something that, at this point, it's still being, just like I'm saying, it's like mental health, we are so far in our research and coming to the 20th century as compared to, cancer research and other research in the medical field. A lot of people are putting more money in, cancer and Alzheimer's and all these, well, that is not even Alzheimer's is kind of, but, in all these medical researchers and not a lot of funding going into any of these mental health. So we do know everybody, nobody can specifically tell you what exactly in one genes, is prone to, having different things than, the other. That is an answer that is not, is not readily available. We just know that some people have the genes and it is passed down. I had a family member who said, oh, I started talking to my family member and my uncle always, when, he sits in the back of a car, he doesn't like it. Oh, he said, oh, multiple uncles or different people, when they sit in the back of the car, they don't like it, but they didn't really ask them like why they don't like to sit in the back of the car. They always want to sit in the front of the car. Then they finally started asking questions because this person came with anxiety. And so these uncles and aunties in the family, all these things that has been happening, it's a sign of anxiety. You can't sit in the back of the car because you feel crowded, because you feel like the car is too small, so you don't feel comfortable sitting in the back because you feel like, you're like in a box and you're squished in. So these are, and so we come to find out, and I'm like, well, yeah, that is a sign of anxiety. And so if your uncles are feeling that way and now you're exhibiting signs, that means it is in the family. But when you ask them, they're saying that we don't have any family history of anything. But then I'm like, well, yeah, if they can't sit in the back of the car and be comfortable and relax, but they feel like they're in a box or they're in a small space, which is what, that is a sign of that. So when it comes to that research, we're still working on it. And hopefully there will come a time when we will have more concrete data, when it comes to mental health. Any other questions? And as as we are here, sometimes I can see, sometimes I can see, and maybe in my environment that I'm talking about, the cultural, differences, from us. I was born and raised in Ghana until I was, in my teens early teens that I came here. And so, but I live with, there's like 3 generations of us living here. So I can see from my mom's perspective, my perspective, and my kids' perspective, when it comes to mental health. My kids are very much open to sharing their feelings. Mom, I'm sad. Mom, I'm, mad. Mom, I'm this, I'm that, which is something that, my mom's generation, did not used to say. So in this aspect, if, some of our students or some of our JYs come to, our pastors, and you pray with them and you talk to them, just like, also, if you're not really comfortable talking to them more about, how to let their feelings out on all these things, then let's make sure that we connect. One of the things that we are working on as the JY committee, or what are we? As the JY overseers, is that we're trying to come up with an initiative for how we can help our JY in this, to have a better understanding and to have a better reach in the church area, to be able to reach out to somebody. We have a little committee that we're working on to set up an initiative of how do we create a platform or an area for our JYs to be, and even, not even the JY, for the entire church, hopefully at one point, the entire Presbyterian church, to be able to have a mental health, area or arena for everyone to be able to reach out. They can pick up a phone call or text and be like, okay, I'm texting these, this number, to be able to reach somebody who can, help us in the things that, because this is very important for our kids. We're in an age where, social media is taking over everything. And with social media, you can't really censor, or, it's not in your hand to censor you personally and your household what comes through. Yes, you can with your kids put some, blocks and whatnot on there, but they go out there and there's so many things that they get out there. You're raising them from within. So that's why I always say we need to put a lot more Jesus in them, so that when they go out there, the things that come at them will just, they will have like Pam on them. So anything that gets thrown at them will just slide right off of their body and not get into their body. So please, please, please bring your kids to church, bring them to church. I will drag my kids to church. I will admit it. I will drag you to church. If you're not coming to church, I'm bringing you. A lot of my JYs that I talk to, why are you at church? My mom made me. Great, mom, bring them. I'm like, you get dressed in the next 15 minutes or you're going to church in your pajamas. That will be me. I will bring you to church in your pajamas. You are going, but we do that. And I tell God, I'm like, God, I'm doing my part. I'm bringing them. Holy Spirit, you do the rest. You do the rest. This is a warfare. This is a warfare.
Yeah.
Our kids are being attacked.
So true. It's so true about that. We need prayer going forward. Some of these things, we can do all that we can, but we have to support it also as Christians with our belief in prayer and all that. And I believe when we do that, that can also help us. Do we have any more questions? I know people are dropping off the line. We were 64.
Yeah.
We are now 49. So do we have any more questions, please?
So I think someone said,
if you have any question, please, you can go ahead and ask your question now. If you can, yeah. Does anyone have a question?
Someone says, can you explain more about how the JY teachers can help the teens? This is a Messi or Bro Eric, you want to take this? Because I have just been talking, and if you give me the chance, I will probably talk till tomorrow.
Okay, so because of time, and I'm wondering, is this, I'm not sure who this, because I'm wondering if you can reach out and then we can provide more support. But just utilizing, and we can share these slides or more information to put on the page. So if you identify these symptoms, then we can talk about you can do your part. But I think as a JY leader, without,
so maybe Eric, can you go to the back slide where it had our information on there? Yeah. So maybe you guys can take our phone numbers and you can text, or I would not say call, because if I don't know your number, honestly, I will not pick up. But if you can text me first, and be text like,
call.
Hey,
but just quickly, I think the first thing is being the kid being comfortable enough to talk to you. If you can get them to open up to you, that is the big part of the problem. And when they come, just be open and just listen to them, and take notes and whatever, and then we can take it from there. So please, you can text or call. I mean, whichever you're comfortable, and we'll figure it out together. I want to be mindful of everybody's time.
Do we have any further questions? Our resource personnel have their contacts here. If you have any questions and you can ask right now, you can do that later. You can text them or email them or whatever means that you might deem possible or necessary. Without much ado, I would like now to call on, maybe they might want to give us their final words before we move on to our sister Veronica Santi to give us the vote of thanks. If they might want to give us their closing remarks.
Yes, I want to just say something brief, that no matter what, our kids or our junior youth are exposed to this environment. The challenge of the temptation is going to be there, but we will do our part. And as we pray and seek the direction of the Holy Spirit, it might be a one sentence or a statement that you would say to a child. It can go a long way. So thank you so much for listening.
Sister Mercy, you also want to give us your closing remarks?
Sure. I just to piggyback on what it is a reality. It is happening. We shouldn't dismiss it. However, we shouldn't also encourage certain things, because it doesn't help. And so it's best that if we identify the problem, we encourage them and help them to find the right path. And yes, it's also, it's not right. We help them with prayers, we talk to them, and we connect them to the right resources so we can make them better citizens of the society. Thank you.
And then our president, Madam Dallas, if you also want to give us your final closing remarks. Please unmute yourself.
Thank you. So sorry. So many things are happening around here. Yes, just like Sister Mercy said, this needs to be an ongoing conversation. Sorry, I did an Instacart and they just do it. This is an ongoing conversation. This is real. We need to make room for our JYs to come and talk to us, and we need to be honest. I always let them know that yes, everything you've talked to me now is private, but if you're hurting yourself or something else is going on, we need to get parents involved. We don't need to blindside them. And getting parents involved, sometimes we might talk to our pastors to be able to maybe talk directly to the parent, and we can focus on the on the JY, because they are because sometimes parents hear this and it blows off the top of their head, and they are very anxious about things, and sometimes the way things can be handled, maybe so maybe the pastors can deal with the parents and trying to explain things to them. And then so hopefully, and I'm just throwing this out there, maybe one day we can have the platform to also present maybe something different to the pastors on a different level, to be able to share other things with them. So let's keep this conversation going. We did put our information on there. You're more than welcome to text, to WhatsApp, I don't have any social media, but if you text me, I promise definitely, or WhatsApp, I promise to get back to you. And we are all very much available to any one of you. Thank you so much, really, for being here, for listening. And we hope that, this will continue going for us. Thank you.
Wonderful, wonderful. Thank you, thank you, thank you. At this point, we'd like to call on our sister, Mrs. Veronica Santiago, to give us the vote of thanks. And then from that, Papa will give us the benediction and close us.
Amen.
Amen.
JY.
Amen.
Youth for Jesus.
We thank God for how far He has brought us. We thank God also for making it possible for us. And we also thank Him for giving our facilitators this knowledge to impart on us. We are grateful to Him. We also thank our facilitators indeed, good job done. Because to me, you have done your best, but I am feeling that maybe next year we have to take it topic by topic. If it is anxiety, only anxiety. If it's stress, only stress, so that we can get enough time to ask more questions. And also, we know the attention span of our kids. They cannot stay more than 1 hour and 2 hours. But in all, you have done a good job. Thank you very much. Now we have known how to deal with these young ones and their problems. Thank you, and may God bless you all and give you more knowledge, so that whenever we need you, you can also come and then give it to us. We also thank our Papa Sesu for all the time spending on us, giving us directions, and then leading us in all this. We say, Papa, God bless you. And to all the Reverend ministers on the platform, God bless you all for your support and your prayers. JWA leaders, thank you also. And I hope what we have learned today, we are going to use it to help our kids and direct them the right path that will make them see the kingdom of God in them. And to everybody on this line, God bless you all for coming. Thank you. Thank you very much. Amen.
Amen. Amen. I don't know about you, but I have learned a lot from mental health today, from the archaeological aspect of it to the zoological part of it. Thank you so very much. Thank you. We'll now call on Papa Sasu to give us the benediction and closing. Papa, if
looks like Papa Sasu is very busy, so I think I can say maybe we can all share the grace together, because for Californians there's another district council
program. There's another district
so,
program
yes,
going on. I can see Papa very busy on something, but
yes.
Yes. On that note, let me give this announcement very quickly. There will be a council meeting, but before then, on the 6th, which is coming Monday, executives, we are meeting on the line, and then I'll post that on the executive platform. And then we'll talk about our council meeting that will be coming on somewhere on the 18th. I think Papa can now say, Papa, if you can hear us.
Well, I also do see the clerk of Presbytery, Papa Ujampo. If you want to say a word or two to us, that would be appreciated.
Yes, Papa, Reverend Dr. Ujampo, the clerk of the Presbytery, has also joined us for some time now. And let me also say that we have the Presbytery YPG Secretary, Madam Charlotte Jandria, also on the line. There are some other executives as well on that, but let's allow Papa Ujampo to give us a word or two before we acknowledge the other executives here present.
Yes, thank you very much. You know, in science, after they have drawn the conclusion of the experiment, you don't need to add anything again. So the conclusion has already been drawn, and therefore we want to say thank you for the good presentations you have made. Presbytery, we are behind you, and we are always supporting you. We wish you all the best, and may the Lord bless you. So feel free and continue. I'm just behind quietly. Let the right people help you, okay?
Thank you, Papa.
Thank you, Papa, for supporting us. We have the Presbytery YPG Secretary, Madam Charlotte Jandria. We acknowledge your presence, and all other ministers that we might not know but are on the line. We say thank you to all of you. I can see my brother Mark Metal from New Jersey, the former YAF Presbytery Secretary, is also on the line. Thank you for coming, and all other people that I don't know. And my New Yorkers, I can see quite a few of them over here. I can only see C, and that's it. And then people from Washington, I don't see anybody apart from Sister Mercy. She's the only person I've seen. So if you are here, well, thank you all for coming. Let me allow Papa now to give
Papa
us
Sasu, are you available?
Papa, very much. Sue is on the line. Papa
Oh, yes. Papa Berima,
Our organizer, our treasurer, actually, our treasurer, the presbytery treasurer for the JY leadership, Papa Berima Bewia. Oh, no.
Papa Berima,
no, yeah, sorry. Yeah, it's also on the line, our district minister for, is it California, right? Am I right?
No,
Can you correct me, my president?
Nana Bewa, are you talking?
Yes, Sacramento. Papa Berima.
Okay. Papa, we acknowledge your presence. Thank you so very much for coming. God bless you. Papa Sasu, can you hear us? Can you take it from here?
Give us the benediction, please, Papa.
Well, dear, I'm running 2 meetings.
Concurrently.
I'm running 2 meetings. That is why. The program has been very exciting, very insightful. The JY Leadership Fellowship, we have a committee that is going to work to come out with some paper and guidelines to deal with this issue of mental health. And, the presenters are part of the committee, and we will also ask if you are an expert in this area, and I'll reach out to any of the JY leadership and we'll see if we can get you involved in the process, because we want to set up a team. There can be a team of experts that people can go to internally before they seek for help, even externally. And at least we have a team within our church people can feel comfortable to talk to and to interact with. And so more details will be coming out, I believe, early part of next year with our internal. Where the for us for such a great program, and all those who contributed to it. Thank you so much. Senate Mokaya and Penny for Asafum Penny for line so. And so if the district presbytery clerk is still on the line, then Papa, can you bless us as we wrap up for tonight? Papa Doctor.
Yes, sir. Yes.
I can still already.
Shiraye. Oh. Thank you. So in the Presbyterian Church, in order not to put yourself into trouble, we are all sharing the grace, saying,
May the grace
of our Lord
Jesus Christ,
the love of God,
the love of God, and the fellowship of the Holy Spirit be with us now and forevermore. Amen.
Thank you, guys.
In the present church, when you don't know the number of senior ministers on the line, you save yourself by sharing the grace.
The headache, huh? Okay.
That's a very good one. I've just learned that.
Priority.
Thank you very much.
Get it. Thank you, Papa. Bye, everyone.
we haven't even engaged the session in the congregation.
How do I get out of here? Oh, there we go.
Very well, and we need to have some conscientization, education, allay people's fears and concerns, and in order to have a smooth transition. So let us tread cautiously, even though we know there's a need for something to start here. Thank you.
Thank you. Now we take Mr. District Evangelist, and then we come to you.
That's it. I